Welcome to Connected by Health. I'm Dr. Krishna Vedala. This is where medicine meets leadership, innovation, and humanity with one goal: to add value and help change healthcare for the better. If you believe health is about more than a diagnosis, you're in the right place. Before we begin, a brief content note. Today's episode discusses healthcare costs, systemic inefficiencies, and financial accountability in medicine. While nothing here is graphic, some listeners may find discussions about healthcare spending, access to care, and system pressures stressful. Listener discretion is advised. Today, we're diving deep into accountable care organizations, or ACOs, one of the most ambitious payment reforms in modern U.S. healthcare history. You probably have already heard of the term. You may actually work in one. You may even be measured by one. But understanding what ACOs actually do and what the data truly shows requires stepping back from a bunch of buzzwords and looking carefully at the evidence. Today, we're going to walk through why ACOs exist, how they actually function, what CMS data tells us about cost, quality, and equity, where the model struggles, and where accountable care may be headed next. So, first off, why do ACOs exist? And what is the primary problem that they're trying to fix? To understand ACOs, we have to understand the system they were designed to reform. For decades, American healthcare has operated under this fee-for-service payment system, which is basically any time that you get a service from a health system or a provider, then automatically you end up paying them a fee based on the number of services that they have provided you. So essentially, in this model, providers are paid for every visit, every test, every scan, every procedure, and every admission. So basically, more care equals more revenue. So there's more of an incentive for hospital systems and providers to see more, do more. So the problem with this system is that the fee-for-service does not reward coordination. It does not reward prevention because obviously we want sick people in a fee-for-service system because that's how you make more money. Neither does the fee-for-service reward keeping people healthy and out of the hospitals. And so the result of that has been very predictable. As a result, the United States spends nearly twice as much per person on healthcare as other high-income nations. Yet, unfortunately, we still see worse outcomes in areas like life expectancy, maternal mortality, and also management of chronic disease. We don't lack technology. We certainly don't lack skilled clinicians, including yours truly. We lack aligned incentives. That's the problem. So by the late 2000s, policymakers, economists, and clinicians increasingly agreed on one thing. You cannot fix healthcare costs without changing how care is paid for. That realization set the stage for accountable care and for ACOs. So let's look at something that will give us an even better understanding of ACOs, and that is the origins of accountable care itself. So the idea of accountable care didn't just originate with the Affordable Care Act, also known as Obamacare. In fact, the phrase itself, accountable care organization, was first popularized by a physician economist by the name of Elliot Fisher and his colleagues in the mid-2000s. And their research showed something very striking, that geographic regions that spent more on Medicare patients did not necessarily deliver better outcomes. More spending often meant more fragmentation. fragmentation or breaking down of care, not necessarily better care. So the Affordable Care Act in 2010 didn't really invent accountable care, but it gave it a pretty big spectrum, a national testing ground. And rather than mandating participation, the Accountable Care Act took a pretty cautious approach. It instead invited providers to participate voluntarily with shared savings as the initial incentive. The logic was simple. If providers were willing to be accountable for total cost and quality, Medicare would reward them. And if it didn't participate, and if it didn't work, the participation itself would fade. So what do ACOs actually do? So let's define this precisely. An accountable care organization is a group of physicians, hospitals, and other providers who agree to be held accountable for the total cost and quality of care for a defined population. So that could typically be a small practice involving a few providers. It could also be a health system that's large enough, or it could also be a group of hospitals coming together with like-minded resources and similar demographics. Specifically, a common example is rural hospitals that may not have the resources that the bigger urban or suburban hospital systems may have. So patients then, once you have the defined population set, patients are typically assigned or attributed based on where they receive most of their primary care. This is important. Patients do not enroll in the accountable care organization. They maintain full freedom of choice. ACOs do not replace Medicare benefits. They sit on top of traditional Medicare, changing incentives behind the scenes. Now, there are four elements that define an ACO. First, a spending benchmark set by CMS. Second, quality performance standards that must be met. Third, population health responsibility, meaning the ACO is accountable for care across settings. That includes outpatient, that includes inpatient, and post-acute. And fourth, financial accountability, meaning shared savings and increasingly shared losses. This structure is what makes ACOs fundamentally different from pay-for-performance programs of the past. So how these benchmarks and the process of attribution works. So benchmarks are one of the most misunderstood part of ACOs. CMS sets a historical spending baseline for each ACO based on the prior costs of its attributed population. That benchmark is then adjusted for factors like patient risk and national spending trends. Attribution itself is always retrospective. Patients are assigned after the performance year based on utilization patterns, primarily through primary care visits. And this is the reason why primary care is at the forefront of healthcare. Now, this design choice matters. It means that ACOs must care for all patients who show up, not just the ones that they think are simple good risks. But it also means that success of the ACO depends heavily on primary care relationships, on care coordination, and also on data infrastructure. Now, when it comes to data infrastructure, that is a whole topic by itself. There has been tremendous improvement and coordination in terms of data utilization and data sharing over the past decade. And it is also a field that continues to grow and develop on a rapid pace. Now, since we've talked about attribution, let's look at the next significant component of ACOs, and that is Medicare Shared Savings Program and what the scale of this shared savings program relates to. The Medicare Shared Savings Program, or MSSP, is the largest ACO initiative in the country. As of the most recent CMS reporting, about 476 ACOs participate nationwide. They serve more than 11.2 million Medicare beneficiaries. That represents over half of all traditional Medicare patients. CMS has set an explicit goal: 100% of all traditional Medicare beneficiaries in an accountable care relationship by 2030. This is a profound shift in how Medicare defines success. Whether if this is going to be achievable or not remains to be seen, given the chaotic changes that happen regarding healthcare systems whenever there is a change in administration in Washington, D.C. So we'll see if Medicare will actually be able to reach that goal. Once again, that is that 100% of all traditional Medicare beneficiaries must be in an accountable care relationship by 2030. And currently, we're at about 50%. So since we talked about the shared savings, let's talk about a very important question next, and that is, do ACOs actually save money? And here, we're going to be looking at the hard numbers when it comes to ACOs and saving money. But first, let's actually talk about some results. So in 2024, ACOs generated approximately $2.4 billion in net savings for Medicare, the highest total since the program began. About 75% of ACOs generated savings relative to their benchmarks. 75%. Again, that's 75% of ACOs generated savings relative to their benchmarks. Total gross savings reached approximately $4.1 billion, with shared savings paid back to providers who met quality standards. On a per-patient basis, now this is on a per-patient basis, net savings averaged about $241 per beneficiary. The gross savings were about $643 per beneficiary. These savings occurred without any benefit cuts and without evidence of any systematic underuse of care. Now, that matters. That matters because it shows to us, to a degree, that this system of ACOs perhaps is resilient, but it also is working. What are the risks? What is the downside of ACOs and why it changes care? So early ACOs, in the beginning, right after the Affordable Care Act passage, early ACOs were allowed to participate in upside-only models. But CMS data consistently shows that downside risk actually produces stronger results, surprisingly. In 2024, ACOs accepting downside risk generated more than 2/3 of total Medicare savings. These organizations invested more heavily in care coordination, analytics, and primary care design. Risk forces hard decisions and meaningful transformation. So what are we talking about when we're looking at downside risk versus upside risk? I think that's a topic that we need to clarify before we move forward. So downside risk basically refers to the potential for financial loss or negative returns on an investment, while an upside risk represents the potential for unexpected, positive, and outperforming gains. Now, downside risk is always about protecting capital, right? Whereas upside risk focuses more on growth potential. So now that we've addressed the topic of risk within ACOs, let's look at quality performance, and specifically when it comes to just beyond cost. Quality performance remains very central to ACOs and to their success. In 2024, nearly all ACOs met CMS quality thresholds. Improvements were seen in a variety of different chronic illness management, specifically diabetes management. There were improvements that were seen in blood pressure control. There were improvements in preventative screenings and also in care transition, specifically from the inpatient to post-acute to outpatient settings. There was also a notion that patient experience scores remained stable or actually in many cases improved. So critically, CMS has not found evidence that ACOs broadly restrict necessary care to generate savings. And that's important. That's important because it means that ACOs are not necessarily taking care away when it's needed, but are rather doing what they're supposed to be doing, which is providing for accountable care and care that also provides good quality at an affordable cost. So who succeeds in an ACO and why did they succeed? Performance patterns are clear. The strongest ACOs tend to be physician-led. They tend to be primary care centered, since again, primary care is at the front line and the forefront of a healthcare system. And of course, also ACOs that are successful also tend to be community-based rather than hospital-dominated. This reinforces a core lesson of accountable care, that strong primary care is the engine of value. Strong primary care is where quality comes from. I know we keep hearing this term that gets thrown out there these days due to popularity, which is longevity medicine. Longevity medicine really is just very good primary care at the end of the day. So when we look at the success of ACOs, we also have to address the criticisms and the limitations of ACOs. ACOs are not without challenges. They're difficult. The administrative burden is real. Reporting complexity frustrates clinicians. Clinicians are not data scientists, and that is something that I will be the first one to admit. Despite the challenges associated with providing clinical care, data science and data management and data utilization is a skill that comes only with practice, which unfortunately clinicians do not have the time to do. So it is no surprise that the complexity of reporting does frustrate clinicians. Another concern is equity concerns. They remain very central. CMS has acknowledged these limitations and is increasingly embedding health equity adjustments and social risk considerations into newer ACO models. So, in summary, today I hope you've had a good understanding of what accountable care organizations or ACOs do, what are they composed of, what are the great things about ACOs, and what are some of the downside things about ACOs. We've also talked about upside risk and downside risk, and also about shared savings. But where does this leave us? Accountable care organizations are not a cure-all. They are not the only solution. But they represent something that is very rare in the American healthcare system. And that is ACOs provide a payment model that rewards outcomes over volume, coordination over fragment. The data shows that accountable care can lower costs, maintain quality, and begin real system reform when designed thoughtfully and supported properly. Because, my friends, if we want a healthcare system that is sustainable, that is humane, and that is patient-centered while at the same time keeping an eye on quality and cost, accountability itself cannot be optional. It has to be built into how we pay for care. Thank you so much for listening to our podcast today. And if this episode helped clarify accountable care organizations or ACOs, please feel free to share it with a colleague or a policymaker or a patient. Thank you so much. If you found this conversation valuable, share it with someone who could use it. And if you're on Apple, we'd love to hear your favorite takeaway and a review. See you next week.